when I can. But Dr. Lipman, let's start with you. And I want to start with some of the complaints. I don't want to use the word complaints, some of the concerns that your patients have when they come to see you, and how you handle that and what you've seen and how you were able to treat their ailments.
Well, I see patients suffering with fibroids. I've really dedicated the last 25 years of my career, and I see almost exclusively women suffering with fibroids. So I have a very unique practice. And so every day I see women that have been suffering, many of whom for years, with this problem, because frankly, a lot of doctors that see patients with fibroids kind of dismiss their heavy periods. And so we can talk a lot about that. I mean, I think heavy menstrual periods are a really significant health issue that's not only underappreciated by healthcare professionals, it's also underreported by the women that they serve. And the reasons for this are really multifactorial. I mean, I think, you know, some doctors don't listen to patients. You mentioned about me taking the time. When I see a patient in the office, it's at least 45 minutes to an hour of, you know, physician time. And I'm in solo practice. There are no other providers. Myself, and I've recently added a doctor of nurse practitioner to my practice, but I'm the only physician. And so I can take the time and spend the appropriate time with these patients. And there's a lot of doctors that won't treat heavy periods unless the patient is anemic. In my opinion, if the woman's period is interfering with her quality of life, it needs to be treated, period, pardon the pun. But if it's affecting her quality of life, it needs to be treated. And so, you know, some women don't appreciate the fact that what they're bleeding is abnormal because they've been doing it for so long. Just because it's been going on for a long time does not make it normal. So sometimes the woman's not appreciating the fact that this is abnormal. And so she might also ask her mom, and her mom had fibroids and had a hysterectomy and suffered with heavy periods. So now they think it's this familial thing. Well, we're just heavy bleeders. No, it's abnormal. It needs to be treated. And there are ways, very good ways to treat this. And now we have excellent non-surgical options. You mentioned Accessa. There's an outstanding procedure that I've been doing the last 25 years called uterine fibroid embolization. It treats all the fibroids in the uterus. Doesn't matter if you have 1 or 100. It's completely outpatient, non-surgical. My patients go home the same day with a Band-Aid. That's it, and their uterus. So that's what I see every single day at the Atlanta Fibroid Center. Preaching to the choir, because to say I've been doing UFE for 25 years, yet I see women every single day in my practice who've never been told about it, never heard about it. They've seen multiple gynecologists, never mentioned, only mentioned hysterectomy, never mentioned UFE, not once. And so I've been living that for the past 25 years. So we know very well, you know, about being kind of ignored. And just because we've been doing something for so long doesn't mean it's the right way to do it. And so we've got to start being more thoughtful and more careful about female parts. I mean, as I say, there is no reason whatsoever for a woman to undergo hysterectomy as a first line or an only line treatment. That just shouldn't be done anymore. I think we can all agree on that.
Yeah, I would totally agree. You know, the other thing, especially when it comes to Accessa, what I've heard is that doctors are frustrated with insurance companies because a lot of insurance companies don't cover some of these other procedures. And when we talk about access, you know, it's not just going to a doctor who has the expertise in these various treatment options. That's obstacle number one. Obstacle number one is getting the diagnosis. Obstacle number two is finding a doctor who can treat you and treat you reasonably without taking your uterus. And then, you know, obstacle number three is how do you pay for it? And so it's all very, you know, tied into the problems of women's health not being given the value that it deserves.
Well, I'll tell you, we're part of involved in legislative issues. UFE has been covered by every insurance company. That's not an issue for UFE because it's been around for so long.
Mm-hmm.
It is an issue for Acessa.
Mm-hmm.
But interestingly, I'm part of a group that's looking at this. There's a legislative effort in Rhode Island currently. A legislator in Rhode Island is advancing legislation to have insurance companies cover all the options for fibroids, including myomectomy, hysterectomy, and Acessa. Okay? No mention of UFE.
Mm.
And we're supporting the legislation. But we just want her to add UFE. But can you imagine? Acessa has not been around that long, but yet here's this legislation which, with good intentions. We know the legislator that's putting this forward, she had good intentions. She wants everything covered, including Acessa, but she had no idea about UFE. It wasn't told about it. And so it was left off the legislation. I mean, so that, you know, again, this is the kind of thing that, you know, kind of crosses, you know, our disciplines.
Yeah, it's the red tape, it's the bureaucracy, and then it's also the lack of knowledge of things that are out there to treat.
Absolutely agree. I mean, we have a very good collegial relationship with a lot of gynecologists in our area. In fact, I'm friends with Suzanne. Suzanne converses all the time with me and what we're doing. So I've known Suzanne for a long time. In fact, I knew her when she was training at Stanford. I'm a lot older than her, so I can say these things. But we have a great relationship with OBGYNs, and it's a respectful, you know, cooperative effort, which is really important because I bring certain skills to the table with interventional radiology. My gynecology colleagues bring certain surgical skills and other medical skills to the table. Patients benefit the most when everybody brings their skill set to bear on a patient to help them. So we are much better together than in silos. And we do a lot of procedures together. For instance, if somebody, and I presented this data at AAGL a number of years ago, we do this procedure called a combined approach, where if there's a fibroid that's in the cavity, say a 4 centimeter or 5 centimeter fibroid that's a type 0, FIGO type 0 in the cavity, and then she has all these other fibroids with all the symptoms that go with it, how do you treat this patient without surgery? Well, you can with this combined approach. If you embolize the patient, it knocks out all the fibroids, including the one in the cavity. Now, the one in the cavity is going to abort. And so that's what you're worried about, it coming out and her passing this thing. So we do this already in advance. The gynecologist is going to take this out hysteroscopically 2 to 3 weeks after the UFE. It works beautifully. All the fibroids are dead. It's easy to come out. In fact, the gynecologists love those cases. I refer them all the time. They love doing them because it's so easy because the fibroid is dead. And they have a lot of fun with it. So again, it's 2 procedures, but there's no surgery involved, and it's very cooperative, and the patient benefits. It's just a great working relationship.
Can you tell us, you know, all of the different diagnoses and treatment options that you were told about, the ones that you weren't, and where you are today?
Yes. It's exactly the same procedure. It's just sometimes we do uterine artery embolization for adenomyosis, which is a condition that has symptoms just like fibroids, namely heavy periods and pelvic pain, but it's not due to a fibroid. It's due to a condition where the lining cells are actually going into the deeper muscle layer of the uterus, and so it can come in focal forms called an adenomyoma and can mimic a fibroid, and it can be very diffuse, either regionally or even globally thick. In fact, we see a lot of patients that have been diagnosed with fibroids that don't have fibroids at all. Some women have had this diagnosis for years based on office ultrasounds, which mistook someone with an enlarged uterus, and they gave them fibroids because, you know, let's face it, we know that fibroids are particularly disproportionate to African-American women. So if an African-American woman goes into an office with heavy periods, the physician is already biased to fibroids, let's face it. And sometimes, you know, you get this office ultrasound, the uterus is enlarged, she has all the symptoms of a fibroid, you get that label because, the doctor didn't spend enough time talking to the patient, that it wasn't enough, physical exam and so forth. So she gets labeled with a fibroid. And when I get an MRI, I don't use ultrasound. MRI is way better than ultrasound, and they are comparably priced. In the old days, they used to be very different price. MRI much more expensive than ultrasound. Now they're very comparable. So MRI is way better than ultrasound. We pick up all sorts of stuff that we never would see on an ultrasound. And so you can diagnose adenomyosis very effectively. And really, there's only two treatments for adenomyosis that have been shown effective: hysterectomy and embolization. You can't do these other things for adenomyosis, at least not yet. Some people have tried to surgically cut it out, but particularly in the diffuse forms, it's hard to know where you are. You don't have the fibroid is a discrete ball. Has good surgical margins. Adenomyosis is more diffuse, and we've gotten very good results with embolization for adenomyosis. So UAE and UFE are interchangeable. It's also covered by every insurance. We talked about that. It's totally outpatient. It doesn't matter how big or how many. There's a lot of urban myths about fibroids. You talked about the fertility aspect. We've had numerous children born after UFE. I've had multiple sets of twins. Now, it's a longer discussion, and I don't want to minimize, it's just saying everybody should get UFE, but we've had lots of children after UFE. It's a longer discussion, and certain patients benefit, I think, from myomectomy the younger you are, and truly the fewer number of fibroids you have. Whereas an older patient, and by older, I don't mean old, but our patients that are going for fertility are usually 35 to 45. And so these are older than the 20-somethings. So the older you are and the more numerous. We see patients with 50, 60, numerous fibroids. Myomectomy is going to be challenging to do somebody that has 50 or 60 fibroids, whereas UFE will knock them all out. And so the chance that she will need something else is very small with UFE. I mean, I've seen way too many women that have had 2, 3, I've seen even 5 myomectomies, and now they're coming to me. And so each time you're cutting on that uterus, the fertility is going to diminish. So everybody's got an impact, and you got to look at each patient individually. Certain patients will be better with myomectomy. Certain patients will be better with embolization, and you got to kind of be honest about it.
Yeah, you bring up a really good point because, in terms of my own personal journey, I went to a gynecologist. My uterus was enlarged. Dr. Ruth, I think that you said if you had looked at someone my size and stature, you would have seen an enlarged uterus. And I remember the first doctor I went to got an ultrasound. It was 8 by 10 by 11 centimeter fibroid. And her advice was, if it's not causing you any problems, just leave it there. And so my mom is a doctor. She said, I don't like that. Go to a fertility doctor. Because at the time I was maybe 32, 33. And the fertility doctor was like, I don't know why you would ever leave a benign tumor in your body just because why would you do that? So she sent me to the doctor who did her fibroid surgery. That doctor, the first thing she did was get an MRI. And I came with like the ultrasounds, and she was like, I don't care, get an MRI. The ultrasound showed 3 fibroids. The MRI showed 6, I believe. She did an open myomectomy. We decided it was best because I had this huge fibroid, 2 medium-sized fibroids. I wanted to get pregnant and have babies. And she's like, my preference is to pull everything out and look at everything closely. She ended up removing 10 fibroids. But she was that doctor who was like, this is what we need to know. Like, we need to know what's going on with you. I don't care if you don't have heavy periods or not. I'm looking at your uterus and it's big. And so she wanted to get it treated. So I believe, Dr. Lipman, that you talked about the infertility, because the people are asking a lot of questions about that. Someone did ask, if estrogen is a cause of fibroids, why is birth control a treatment of fibroids?
What we do is we try to add exercise and weight loss, because it seems like estrogen definitely plays a role. We don't know where they come from, but clearly it seems like estrogen has a role. And the reason we think that, a number of reasons, one of the reasons why African-American women disproportionately suffer with fibroids has to do with body fat, and estrogen is stored in fat. And that's, if you look at racially, body fat distribution by race and fibroid incidence, they're very comparable. African American at the top and Asian at the bottom. Now, we see a lot of women, as you mentioned, with very low body fat and big fibroids. They have a genetic part of it. We can't do anything about picking our parents, but we try to do an anti-estrogen approach. So we try to tell them to limit hormonally rich foods. We try to tell them to eat more fruits and vegetables because they have flavonoids in them, which can block an enzyme that's important for estrogen synthesis. Vitamin D is real important. Only 10% of African-American men or women have adequate vitamin D. We know that vitamin D is a powerful anti-fibroid growth. It's actually a hormone. It actually prevents fibroid growth. Also, green tea extract seems to be very good too. But checking your vitamin D level is really important. It's simple and you can supplement it. And that's a really good strategy. So exercise, lose that excess body fat, eat healthier, and know your vitamin D and get that adequate. You're going to have a very good strategy to try to keep those fibroids at bay. Because I feel like I'm a mechanic. I'd like the patients to keep the right fuel in their car, take their car maintenance seriously. But when it breaks down, you're calling an OBGYN or you're calling me to fix the problem. It would be much better to get it on the preventative side so you wouldn't have to have these challenges.
Someone is asking, what if you are not a candidate for UFE? Do you then take it to the next level?
Well, almost every single patient that is a candidate for hysterectomy is a candidate for embolization. It's almost everyone is a candidate. And again, these are part of urban myths. Many of the myomectomy patients are also candidates. So there are not many people that are not candidates that are deemed candidates for surgery, either myomectomy or hysterectomy. There are some, and there are some people that we would say, well, you probably will be better served with surgery than embolization. But the vast majority of people that are candidates for surgery are candidates for embolization. And the one other urban myth you talked about, infertility. There are some people out there that believe that if you're interested in fertility, you can't have UFE. As I mentioned, that's a myth. What the concern is, there are some women that have an embolization that will stop menstruating. And if you stop menstruating, you won't be able to have a child, at least the regular way. You could still do IVF and surrogacy, but the chance of that happening is so low. In fact, I've done over 9,000 UFEs. I've never seen it in any woman under the age of 40. As she gets above 40, you start to see it, but 40 to 45 is 1% to 2%. So you have to look at what is the risk of undergoing myomectomy in patients. How many fibroids does she have? Has she ever had a myomectomy? Because in my opinion, if you've ever had a myomectomy, there's really no reason to get a second one, ever, for any reason. Because obviously you're going to set that woman up for a third procedure, likely, because she's got lots of fibroids that are left behind after the first myomectomy. Now you need something like UFE that can address all of the fibroids, not some of them. We tried, one myomectomy, okay, but the second go round really should always be UFE, in my opinion. Yeah, well, no, I'm talking about live births. We've had numerous live births, and our births, unlike myomectomy, our births are typically full term and vaginal. So whereas myomectomy, you're probably going to get a C-section. I don't think too many people that had myomectomies are going to be allowed to have a vaginal birth, period. Our births are typically full term and vaginal. And so when you talk about obstetric complications, certainly the early data, and it's showed that there was some slight increase in these obstetrical things you mentioned, like placental things and other of those kinds of things. But what it really, when they looked at it critically, there was a kind of a rush to judgment because people, but when you actually look at the data, the reason why these women had premature rupture of membranes, maybe IUGR, maybe a placental abnormality, it had to do with the woman's age, because a lot of these women were instrumented, they've had multiple procedures previously, and so that in combination with their advanced age was really their risk factor. Because I say, I've had numerous live births, I've had multiple twin births. It's not the concern that we had originally many years ago when there was some concern as there was a slight increased risk of these things, but it just hasn't panned out. It really hasn't. Now, I wish we had better data, and I wish we had more research. In fact, I'm very hopeful that HR 2007, that our vice president championed in the Senate, and now has the Stephanie Tubbs Jones counterpart by Yvette Clarke in the House of Representatives, hopefully will become law, because that will provide $30 million a year for 5 years to the NIH to study where fibroids come from. They'll also study women of color who've been left largely out of the conversation in something that affects them more than anybody else. That's ridiculous. It'll also provide important, talking about the different options for fibroids. So I'm hopeful that that's going to become law so that we can really get the needed research, because frankly, the fertility research with embolization is really awful. It's just not very good, and we need more data, definitely.
I have a quick question, Dr. Lipman. I've had about 4 or 5 when I was in residency, and since I've been in practice, have had patients either have chronic pelvic pain after, or they've actually had a fibroid. They've had to kind of deliver their fibroid like a baby after having had uterine artery embolization. And when I talk to my patients, and I noticed that you didn't mention that as one of the things that can happen, is especially if a patient, one of the patients I would say who wouldn't be a candidate for uterine artery embolization is a patient who has chronic pelvic pain at baseline. If she might have underlying endometriosis, and my mentor, Dr. Donald Chapman, did a bunch of laparoscopy on women, and he found out, because women were complaining of bleeding and pain, found out that they didn't have PID like they were told. They had endometriosis. And when you have endometriosis, those patients would be ill-served by not having someone take a look, because as we all know, it's not possible to see endometriosis unless it's an endometrioma within the imaging study. So have you seen that?
The MRI really does afford things. Now, yes, you don't see everything. You can't see the endometriosis.
Implants. You cannot see implants.
But you can see the secondary effects of endometriosis. So when they're around the tubes or the ovaries, they cause cysts or endometriomas or dilated tubes. We know that this is likely going to be endometriosis, and it's something.
Right, but you do know that the severity of endometriosis doesn't exactly correlate with the findings that you see on imaging, right?
Well, I think that, you have to look at each patient. That's true. If you see extra uterine disease of any kind, then likely, something treating the uterus, I can only treat what's in the uterus. If I see a lot of adnexal disease, extra uterine disease, then that patient is not going to be embolized. So we're going to treat patients that have fibroids. Now, are there possible patients that have endometriosis that we're treating that we're not aware of? Possibly, but I can tell you by following the patients, if they don't get better by the 3-month follow-up, if they're not better, then there's got to be a reason why. But fortunately, that's really uncommon. The vast majority of patients at 3 months are transformed. They have their life back. It's women that have been having these gushing, flooding, crime scene-like periods, anemic, lethargic. They're not only physically weak, they're also mentally tired of this month after month.
You don't want kids and you're not concerned about fertility, then it's an easy answer.
Although, can I be the devil's advocate here?
Yes, I would love that.
Because right now, hysterectomy is the 2nd most common surgery done in the United States, which is kind of staggering because half the population doesn't even have a uterus. And the most common reason why we do hysterectomy is for benign disease. If you have uterine cancer, obviously hysterectomy, period, end. But the most common reason why we do it is for these benign tumors, which also disproportionately affect African-American women. And my contention is, I wish everyone was, I wish you represented all the gynecologists, because you obviously went through all the different options, but too many people go right to hysterectomy. I see patients every single day in my office, never heard about anything else. All they get is hysterectomy, and that's got to change, because there are these other excellent treatment options, and there is a there's a downside of losing one's uterus. Again, I don't want to be the male talking about the impact of what happens to women when they lose their uterus, but I over the past 25 years, I've counseled women and learned from them. A number of women struggle psychologically, like a man being castrated. There's a lot of sexual dysfunction after hysterectomy, loss of libido, loss of orgasm. We know there's bone loss with hysterectomy. There's urinary leaking. You take this, a lot of our patients have 16, 18, 20 week size uteruses. You take that uterus out, it's going to weaken pelvic floor muscles. You're going to have you're likely to have a urinary leaking issue. There's all sorts of surgical complications from, I see them because if the gynecologist nicks the ureter, the bladder, the bowel, IR is going to be doing a percutaneous drainage or a diversion of urine. So, I mean, I think that we should be very respectful for a woman's uterus, and it should be, if you're going to take it, there better be very good reasons, and more than just, I'm sick and tired of sick and tired, because I can fix sick and tired. I can transform sick and tired to normal light periods again, and they can then build up their iron and hemoglobin, and they can literally get their life back with UFE. And so respectfully, I would say, consider UFE more often. And there's ways that we can work together to really improve the quality of people's lives without surgery.